Saturday, and welcome to another round of virtual morning report, global edition. Of course, friends from all over the world join us on any virtual morning report, but on Saturday we celebrate the many cultures that join us here today, and are delighted. I'm delighted to see many names that I recognize and some that I actually don't. So I'm excited to meet some new faces, meet some new people, and see some new faces. Um, As per usual, we're going to go around and introduce you to the CP Solvers team members who will join us today. But I think it's going to be based on our numbers. We're about a group of 22 so far. So I think it's going to be a smaller, more intimate group. And as a result, I think we should try to have a conversation that's reflective of the smaller group here. And so maybe I can put out a call for somebody to present a case. If you have a case, please volunteer to present it. And then if you're willing to discuss, maybe we can have one discussant, but priority on a case presenter. And if you have a case, maybe because it's 20 people, we can have Sandra, fantastic, join the conversation. So Sandra and I will discuss the case today, and we'll try to involve everybody, actually, involve the chat since it's a smaller group. But if you have a case, please volunteer to present it. In the meantime, Gabby, hello, good morning. Please tell the VMR community who you are and maybe a little bit of flavor of where you're from in the world.
Hi everyone, I'm Gabi, I'm from Brazil. And what is the other thing that I should say?
Anything about your part of the world.
Yeah, actually I'm going to say a very sad thing because right now the COVID is hitting Brazil so hard, and there's not a good thing that is going on. So I'm very worried about everything.
Yeah, I share your sentiment. Obviously, I'm not there on the front lines, but I think the news from Brazil is very sad and very concerning. And yeah, I don't know if there's any words that will massage the chaos that is happening, but all you can do is do the best you can, put your head down and cross your fingers sometimes, and certainly hoping for the best.
Bueno, hablando con
Oh, hello, Gabriel. He doesn't realize he's unmuted. Hello, my dear friend. Does this mean you have a case for us again? Oh, if Gabriel has a case, I will just quit because the chances of getting it right are essentially zero. Rafa, good morning. Another friend from Brazil.
Hi everyone. Do you want me to say something in Portuguese?
Please do.
Oi pessoal, meu nome é Rafael, eu sou aluno aqui da Universidade Estadual de Maringá. Muito feliz de estar aqui novamente com todos vocês. Realmente é um tempo muito difícil para a gente aqui do Brasil, mas esperar pelo melhor. Hope for the best in the near future for us Brazilians. So thank you everyone.
Absolutely. Zakriti?
Hi everyone, namaste to everyone. I'm calling from India, specifically Bangalore. It's 10:30 in the evening here. And for everyone who's joining from India, we'll all probably tell you that our summers have just started, so it's really hot here. But I'm really excited for today's VMR.
How hot are we talking, Zakriti?
I don't know the exact temperature, but I was wearing a sweater like 2 weeks ago.
Yeah.
And yeah, now I can't sleep without the fan on, so it's very hot.
Oh my God. Okay, that's quite a difference from sweater to fan in 2 weeks. Hans, where are you at? What part of the world are you in?
I hope my audio works.
Yes, it does.
It does, so I found the right button. No, I'm calling from Germany. I'm visiting my mom right now, and because of COVID-19, I'm kind of stuck.
Yeah.
I didn't travel anywhere.
Oh, wow.
I'm originally from Canada.
From Canada. Wonderful. You've been an ever-present on VMR. It's so nice to hear your voice. Tell us a little bit about yourself, please.
Yes, I studied medicine at Ross University. I graduated a few months ago, and now I'm a clinical skills facilitator.
Oh, amazing.
So I can work online in the home office.
Yeah, fantastic. And do you have a sense of what you want to do?
Yes, I applied for internal medicine. Hopefully I might match. I'm not sure. It's a little bit tough.
Yeah, it is. Oh, it's very tough. There's no doubt about that. We wish you the best. And I think at the risk of offending Gabby a little bit, I think you chose the right specialty. But neurology is a close second. A close second. I'm kidding. I'm kidding. For the longest time, I was going to be a neurologist till things random chance happened, and I snowballed towards internal medicine. Yeah, you can totally unmute yourself, Gabby, and throw a punch back at me. It's totally fair game. You're very more than welcome to do it. But Hans, it's so great to hear your voice, and thank you for joining us. We'd love for you to discuss or present a case in the near future. Thank you.
Thank you. Yes, when I'm a resident, I'll definitely come up with good cases.
All right, looking forward to it. Last but not least, Kiara, please say hello.
Hello, and I agree with you, Ravi. Internal medicine rocks. and and I'm so happy to hear your voice. I've seen him I'm almost every day. If you or anyone have a case, it will be amazing. Oh, I have to present myself. I'm Karen from Peru. So I speak Spanish and I will start speaking in Spanish. Soy estudiante de medicina del último año, ya debía acabar, pero aún no se sabe nada y me alegra estar con todos ustedes ahí.
Amazing. Kiara, I'm curious, have you learned any Portuguese since you've been on here?
I know Portuguese, but I'm very shy.
Oh, VMR is all about exploring your limits and boundaries, right?
Yeah.
What have you learned to say in Portuguese?
Well, I've been in Brazil, so I learned there, and I'm very shy because I don't know if my pronunciation is good, but you're totally right. Actually, CPS is a very safe environment, and next time I promise I will introduce myself in person.
Amazing. I'm never gonna forget, right? Don't think that just because you're saying next time that somehow I'll forget.
Oh, okay. I promise.
Rabi, Kushal sent me one case. If you want, I can present it.
Oh, amazing. All right, that sounds good. I see Kushal here. He wants to hear your voice instead of his.
He said he's to sleep because it's supposed to his shift.
Oh, really? That sounds great. Okay, Rafa. So why don't you go ahead and present it, and then Sandra and I can discuss it, and we'll actually try to involve everybody because I think it's a small group in the chat here today. All right.
So okay. So Creedy, can you do the teaching points?
Sukriti is like, hell no, it's too hot here.
Okay, so the chief complaint is cough, dyspnea, and weight loss.
Amazing. All right, yo, chat, rock and roll, do your thing, and I'll try to look at the chat and involve everybody. But Sandra, please go ahead, unmute yourself, remind us of who you are, and a little bit about your culture, and jump on in.
Hi, I'm Sandra. I was born and raised in Cape Verde, West Africa. I studied medicine in Bolivia, and now I live in New York. I'm doing clinical research. Just a fun fact, like I speak 4 languages, English, Portuguese, Cape Verdean Creole, and Spanish. So I can speak in other languages that if you want, but
no, that's cool.
Okay.
we've heard your masterclass before. I'm really curious how you think about cough in general. What does cough make you think of?
Cough. Okay. Yeah. Cough, could be many things. With the information that we have, every time that I have like a symptom, it really depends on the patient, the age of the patient. Basically, if we're talking about cough, it would be important to know the age. Because pediatrics patients have different causes than adults.
Yes.
So cough can range from having a superior respiratory infection and also can reflect something related to an infection that can go down on the lower part of the respiratory system. In general, these are causes, but there are other things that could cause like a cough. Let's say it could be even a side effect of medication. It could be like defense mechanism to something that's irritating.
Yes, the airway, 100%.
Yes. Yeah, in general, that's are my thoughts.
I absolutely love it. Hey, hey, Drew, how do you say cough in Spanish?
It's tos.
Tos. Ooh, fantastic. And Sukriti, how do you say it in Hindi?
Kasi.
Kasi. Amazing. Hey, Tiago, you had a great pro about cough in general, then cough in VMR. Can you please share it?
Yeah, I was just saying that the most common cause of cough is upper respiratory disease. It's the most common cause for acute and chronic cough. But as it's a VMR, it's not the case. And also it does not present with weight loss.
100%. Base rate in real life versus base rate in VMR. I absolutely love it. And my dear friend Rob Weber has is starting to incorporate dyspnea. So Rob, how do you want to just share your reflection in the chat?
Sure. I think I'm just taking it from you, but we use like the dyspnea pyramid a lot, and the base of the pyramid is the pulmonary and cardiovascular system, which on a recent RLR I learned can account for up to 95% of dyspnea complaints. And then if you add on the weight loss, you start thinking, is this an inflammatory cause in one of those systems?
Brilliant. Stands by its own, my friend. I completely agree. Even if it came from RLR, you've soaked it up like a sponge. I also see some very specific diagnoses from Nilan. I'm sorry if I'm pronouncing your name, Nilan. Do you want to unmute yourself and tell us what you were thinking of in terms of these infections? I don't know if you can. I'm sorry if you can.
Everyone. Yeah, it's okay. It's Nilan, but it's okay. I'm very
Lion.
But I thought of it. Hello, am I audible?
Yes, you sound great now.
Okay.
Hi,
so I mentioned histoplasmosis. Hello. Hi. Okay. So I'll introduce myself. I'm Nilan. I'm a third year medical student from India, Delhi, and that's all. Yeah. So about what I wrote.
Yeah.
So I wrote histoplasmosis, as Dhruv mentioned, TB, and they almost go hand in hand. With ascariasis and strongyloides, I thought, see, ascariasis and strongyloides both are nematodes, and if they cause chronic irritation or chronic infection, then they might be able to cause a weight loss. And with the cough, I thought that when they travel from the gut to the throat, I don't really remember the name.
Yeah.
Yeah. So they might irritate the upper respiratory mucosa and cause coughing. And with echinococcus, well, I mean, echinococcus can rarely affect lungs, and it might, and when the cyst bursts, it might cause coughing as well.
Lion, absolutely perfect. I completely agree with you. I think that, it's incredible how the base rate is profoundly influenced by VMR or not, as Tiago outlined, but also where you are in the world.
Yeah.
I mean, the fact that these were reflex things that you know so well highlights how much experience you've had with them, either in the textbook or in real life. And depending on where you are in the world, these infections are either at the top of your list or at the bottom of your list, because they really are so geographically predominant. I just saw a really fantastic comment from Jane about the time course and the possibility of lung cancer. Do you want to just share that a little bit more, Jane?
Hi, everyone. I was just thinking, so I'm a cancer biologist doing my PhD right now. So naturally my head goes to cancer.
Yeah.
But I think for me, the weight loss, that's kind of a common symptom with patients with cancer. So, and then obviously with lung cancer, you can also get cough and dyspnea symptoms. So that's just where my head went.
100%. That comment really grabbed my eye, and I'll reflect on it in a moment. I want it to stand by itself, and I'll come back to it and reflect in a moment. Nalayan, I'll come back to you. Do you can you tell us where in India you're calling from?
Yeah. So I'm from Delhi, New Delhi.
Delhi.
It's the capital of India, and that's.
I have one question for you. If you were to treat us to one delicacy from Delhi to eat, what would it be?
Well, depends. If you are high on street food, then pani puri. You might have heard about it.
Afghani puri is what you said?
No, pani. Pani is
Pani puri.
water.
Yes.
Pani puri.
And what is, describe that? What does that have?
So it's basically spice. Oh, okay. It's okay. So it's basically spicy water.
Yeah.
And you have these puris. Puris is basically fried maida. Okay, how do I say? Sukriti, you might want to help me. I'm out of words here.
That's okay. No, I have some Googling to do, but honestly, you have two people in the chat who already know. Tarek, my dear friend from England, who is a Man U fan, also seems to know much about it, and so does Jane. So I'm the one who clearly is ignorant here, and I'll do my work afterwards. I'll bring us back to the medicine here, and I think Jane was alluding to it, and I think I forget who else who else was doing it, but what is the time course here was the profound reflection early on. If you scroll up to the chat, everyone's like, a lot of people are like, I need the time course, but I'll tell you, you know the time course, you know it already, which is why, Nalayan, you're already thinking about infections that have a chronic time course. So why were we all thinking chronic? We're all thinking chronic because the patient's lost weight. You cannot lose weight acutely. And if you are faced with a syndrome that features weight loss, you know that the time course is subacute to chronic. So whatever effect this is having on the cardiopulmonary apparatus, which Rob highlighted is 95% of shortness of breath, you know that it's taking its time to do so. It's developing so slowly here that it has time to cause weight loss. You're not going to get strep pneumo so slowly that it causes weight loss. Your patient's going to present basically the same weight because their symptoms develop so quickly. So even though we don't know the time course, I would bet, although I'm certainly open to being wrong, as you should never anchor, but you should have some hypotheses. And the hypothesis here is a syndrome of subacute to chronic. But here's the, I think, more profound point. Who cares about the cough here? In the patient who's short of breath, the value of cough diminishes significantly. And I think this is the point that Tiago was making. Most cough is an upper respiratory tract disease process and comes in the absence of any alarm features. Most people who cough don't have shortness of breath. And as soon as shortness of breath is present with a cough, you know that you are dealing with a pulmonary disease process in the lower respiratory tract. So cough basically takes shortness of breath and adds a little bit of localizing value and tells you that your shortness of breath is likely pulmonary in origin. But you already had a 95% chance of having a cardiopulmonary disease process, so you're left none the wiser. But you may come back to me and say, Ravi, what do you mean? 95% is heart and lung, cough equals lung, so do we not eliminate the heart? No, we don't. Because cardiac diseases can result in lung diseases. Classic example, pulmonary edema. Less common examples, anatomic compression from the left atrium on the bronchus, and many other ways. The heart and lungs sit right here next to each other, and any cardiac disease process, pericarditis can irritate the pleura, irritate the lung, cause cough. So cough tells you the lungs are involved, but you don't know if they're primarily involved or secondarily as a result of adjacent cardiac disease. So we're in a world here where we know that the lungs are affected in a subacute manner, subacute to chronic manner, as evidenced by the weight loss. We can't assume that the reason for the weight loss is causing a lung problem. Those are two separate things. Odds are that whatever is happening in the lungs is causing weight loss, but we have to be open to the disease being in the heart, referring to the lungs, the disease being in the kidney, causing pulmonary edema, referring to the lungs, or disease being in the neuromuscular apparatus, causing diaphragmatic weakness, referring to the lungs. So you have to be careful about the localizing value of cough because too many other things can affect the lungs and fool you into thinking that the lung is the primary problem. But the base rate of disease will tell you that it's probably in the lungs. So let's summarize. I learned about pani puri, which is fascinating to me, and I have to learn a lot more about that. I've learned that I actually really enjoy hanging out with the chat and having all of your voices heard, so we'll try to do more and more of that. Sandra reminded us of the millions of causes of cough, really. And then we learned from in the entire community about shortness of breath and the cardiopulmonary localization, from the cough in real life being upper respiratory tract, but in VMR being lower respiratory tract. And fundamentally, at the end of the day, you have to think about what subacute processes exist because of the weight loss. And the question is, does cough localize to the lung? Yes. But does the problem have to originate in the lung? No, it could originate in the neurosystem, the cardiac system, or the kidneys. All right, Rafa, why don't you give us some more data to play with?
Okay, fascinating how much you can discuss just with this. So it's a 61-year-old female. The symptoms started 4 months ago, getting worse since last week. This patient lost 24 lbs in the last 4 months. I don't know how much is that in kilos. We don't use it. 24 lbs.
Yeah.
In the last 4 months. Oh, it's roughly 12 kilos. Okay, thank you, chat. So the cough is mostly dry. The cough is mostly dry and there is no hemoptysis. This patient wakes up in the morning completely drenched from night sweats. Also, this patient has been having diarrhea and abdominal pain, which is more than his usual baseline from ulcerative colitis. And that's the end of Aliquot number 1.
Ah, so good. So good, my dear friend. Sandra, I feel like it's been ages since we talked.
Yes.
Rafa was like, I can't believe you can talk so much about so little, but he was really telling me like, yo, stop talking and watch the time, which is true. It's already halfway through and we only in Aliquot 1. Question for you. You're probably not expecting this question. I would love for you to teach us what you know about the big medical history we got at the end. You see how he snuck that in there at the end? He says, oh, he has ulcerative colitis. What do you know about ulcerative colitis? What can you teach us about it?
Okay, I'll try hard. So I know it's a chronic disease, inflammatory disease, and it can have flares, and it can be controlled under some medication, but also it can lead to situations that it will need a surgery to repair the damage. And it can be associated with bleeding, GI bleeding, the lower GI bleeding part. I think for now, that's what I can tell.
I think that's brilliant. I think, it's a chronic inflammatory disease of the colon that can be cured with surgery. Yep, that can be cured with surgery. I think that's brilliant. I'll say that your understanding of it is very advanced. And I think the question is it related here to the condition in the lungs or is it not? And I think Mario has some great thoughts about one, cough productive versus not, and then questions about could ulcerative colitis cause lung issues. Mario, please unmute yourself and tell us more.
Hi, everyone. Well, I remember a past VMR where there was a very fascinating case. I'm not sure it was ulcerative colitis or Crohn's disease that had, I'm not sure if it was pneumonitis or some other type of lung involvement causing dyspnea. So that's something that came to mind. Not only is it like an immune suppression related cause of dyspnea secondary to a ulcerative colitis treatment, rather in that case was the direct association. So that's something that I remember.
100%. Your memory is spot on. And I think Valeria was there too. Valeria, please unmute yourself and remind us what you remember from that case.
Hello, everyone. I actually don't remember much. I just remember Dr. Greer doing an amazing explanation of how to interpret X-rays and teaching us of an unusual presentation of extracolonic presentation of ulcerative colitis. And I also remember that I believe it was a variant, eosinophilic variant of ulcerative colitis. That's what I remember.
Amazing. You're really getting us on the right track. I know I am looking at the chat now, scrolling back up. It seems Drew was there too. Drew, what do you remember from that case?
Yeah, I think it was actually, I think it was Noah Rosenberg who had he had put into the chat link into the chat during that whole case. There is a whole phenomenon of ulcerative colitis having extra gastrointestinal manifestations, and one of them is this essentially like ulcerative bronchiolitis. I actually have put a link into the chat about an article on it, where you can get this even after total colectomy, which will essentially remove the possibility for GI disease. But because you still have autoimmunity, you may get extra gastrointestinal manifestations of the disease.
Brilliant. I think, Drew, if I could just take a pause and stop all time right now and show people exactly what you did there. You can't remember the specifics of cases. This is like 2 months ago, but I think that your job is with every VMR case to try to distill 1 or 2 facts that will live on forever. And I think that is really fundamentally it. What stuck with me for that case is that the extraintestinal manifestations of ulcerative colitis can continue to occur despite what Sandra told us, that surgery can be curative. And that's, I think, a really, really important factoid. We'll reflect on the ulcerative colitis dimension in a moment, but Tarek is picking up on the other dimension of this case. And the other dimension of this case is the night sweats and the weight loss. So Tarek, if you are able, please unmute yourself and tell us more about your thought process there.
Yeah. I'm just thinking whether the ulcerative colitis is more sort of noise versus signal. Is it related to the underlying pathology or not? If you've got weight loss, night sweats, with cough and dyspnea, you sometimes you think of B symptoms as well, and whether there's something hematological going on, and have you got some sort of lymphadenopathy in the lungs, and could that be causing some bronchial irritation, manifesting as both symptoms? Sometimes you think of carcinoid type tumors as well in the lungs, which can also possibly give you some sort of diarrhea symptoms. But yeah, quite a long list.
Yeah, there's a lot there. But I love it.
You can think of. But I guess it's about putting all the pieces of the puzzle together and see where it leads.
Beautiful. Your conversation stands alone. I absolutely love it. You told us briefly where you're calling from last time. Do you mind telling us a little bit more about where in the world you're calling from and maybe something unique to your part of the world?
So I'm originally from Mauritius, and my great grandparents are from India. Wow. But I came to med school in the UK, and I've been in Manchester since 2012, and I've kind of stayed.
Gotcha. How do you get to go back to Mauritius, or are you really stuck in staying in Manchester?
In the long term, I'd like to go back someday. I mean, the weather's a lot nicer than the UK. And most of my family are there. But career-wise, the UK is probably a better prospect at the moment.
Understandable. Tell us something we may not know about Mauritius.
Something that something that you perhaps don't know.
Yeah. Anything.
Well, apparently the Arabs were the first to actually come across the island, although the Dutch were the first settlers.
I see.
And I think they were also preceded by the Portuguese, but it's difficult to say who came across the island. But the settlers were definitely, the Dutch were the first settlers.
Wow. I did not know that. I'm originally from Lebanon, and so knowing that, we talk in Lebanon a lot about where the Phoenicians went and how far across the world they went, but to know that the Arabs probably made it to Mauritius is really, really intriguing. Thank you for that. So one more thing, Rafa. You were reminding us from step 1, I imagine, of the connection between the lungs and the GI tract. Can you unmute yourself and tell the folks who are listening what you said in the chat?
Oh, it's just the doctor that presented the case reminded us that the lung and the GI tract share the same embryology origin, which is the endoderm, which explains why the lungs and the GI tract are involved in ulcerative colitis.
Beautiful, absolutely beautiful. That's such a great way of remembering it. Okay, so let's come back to the let's come back to the medicine.
And we can remember one other thing. Last Thursday, you showed us that apical lung predominance has HLA-B27,
Yes.
which is ulcerative colitis and Crohn's disease.
Oh my God, you're a sponge. You're a sponge. You remember everything I say, which worries me a little bit, to be honest.
Oh, you're my teacher. I'm counting on you.
So,
okay, so Aliquot number two. Okay.
One more minute. I got to show you something. It's been 30 minutes and I haven't shown you a schema yet. So, that we've confirmed the time course is 4 months, as you all suspected, and we've verified the weight loss. I took Mario's question earlier, like, is it helpful if the cough is productive or not? The short answer is the only time you really care about the color of the cough are two scenarios. In patients with underlying COPD, a change in their mucus production helps you diagnose a COPD exacerbation. So that's one. And the other is when the cough is productive of blood, when there's hemoptysis. Every other scenario that's been studied, the predictive value of cough is very poor. You'll hear red currant sputum telling you it's Klebsiella. You'll hear green telling you it's Pseudomonas, but in real life, those don't pan out. So productive versus not really is a question of, is it a change in a patient with COPD or is it hemoptysis? Those are the only two times it actually is evidence-based or helpful. And, so we learned that, and then, we were in the world of weight loss, and the question was, is there inflammation or not? And the presence of night sweats tells you that this is an inflammatory cause of weight loss. And so we were like, okay, there's inflammatory weight loss. Where is the inflammation originating from? And we're getting we're getting pulmonary symptoms, which we know aren't limited to the lungs. And then we're getting a lot of abdominal symptoms. So the question is, does the inflammation live in the cardiopulmonary apparatus, in the belly, or both? And the problem is that there are a lot of pulmonary disease processes that have mild abdominal pain and diarrhea as a non-specific consequence. We talk about Legionella a lot, causing a lot of abdominal issues, but it lives in the lungs. The same is true of the belly. You could have an abdominal issue causing metabolic acidosis that causes you to feel short of breath. So we still have to be like, are we dealing with a problem here or here that has subtle symptoms referred, or is the problem affect both? And the truth is, it's hard to ignore the fact that we already know a lot about the abdomen. We know the patient has ulcerative colitis. And the connection between ulcerative colitis and the lungs, as you alluded to, is very, very strong. I want to remind you of where that strength exists. So I'm going to share this schema with you. Oh, I'm sorry, wrong one. The focus of the pulmonary every time. What do you guys do? I can't tell what you see. Are you guys seeing IBD plus pulm?
Yes.
Okay, good. Thank you, Sandra. The quickest to the draw. Yes. The focus of the disease of ulcerative colitis and Crohn's on the lungs is in the airway. So most people get airway diseases. And last time it was bronchiectasis, the most common. But it can be subglottic stenosis. It can be necrotizing tracheal bronchitis, bronchiectasis, or bronchiolitis. Why in this order? Upper airway, trachea, middle airway, lower airway. This is an anatomic order. Literally, as we say, Crohn's can affect from the top of the GI tract to the bottom of the GI tract. IBD plus pulm can affect from the top of the lungs to the bottom of the lungs. The other effect is on the vessels. IBD is a hypercoagulable condition, and you can get recurrent PEs. And in patients with Crohn's, they can get Takayasu arteritis. So airway and vessels are the focus of the disease. And because of the therapy we give to people, they can get pulmonary disease toxicity because you have low immune, so you get infection, or you can get a toxicity from the drug. And there's some other rare things. So if you had to remember something, know that IBD's effects on the lungs are in the tubes that go into the lungs, the airway or the vessels. And the tube is anywhere from the top to the bottom. All right, Rafa, let's get more data.
there are two more aliquots. Aliquot number 2. The past medical history, this patient has COPD, bronchiectasis, ulcerative colitis on infliximab. This patient has no surgeries. She's from Colorado. This one is interesting, very crucial. She loves hiking, living in a wooded cabin, I don't know, wooded cabin, swimming in freshwater lakes. This is so crucial. She traveled to Ohio 3 weeks ago and Jamaica 4 months ago. She used to eat raw oysters. No smoking.
Pujal, my mind will explode. What are you doing?
She's a non-smoker or drug use, and she drinks a glass of wine every few weeks. Related to the physical exam, her vitals, temperature 100.8 Fahrenheit, heart rate 103, respiratory rate 22, and blood pressure 115/60/80. 68, sorry. The saturation is 88% on room air, and her BMI is 20. On the lung exam, there are diffuse crackles on lung auscultation. This patient is tachycardic with no murmurs. And there is mild right upper quadrant tenderness, no rash or lymphadenopathy palpated. And that's the end of aliquot number 2.
Mario is already jumping on the food association. So Mario, I'll come to you in a moment to share more about your food associations here and teach us more about the infection you're mentioning. Sandra, I think vitals are vital, so we should really study them first. How do you interpret the vital signs for us here?
So, I mean, the HR, the heart rate, it's just a little bit high. But then she's saturating 88. So that's a concern. To be honest, sometimes I get confused with the temperature because I'm really used to Celsius, and sometimes
that's like 38.1 or 38.2 Celsius, something like that.
Oh, okay. Yeah. Okay. Sounds good. But the blood pressure, it's not concerning for me. So here, what I will be more concerned is the saturation, the oxygen saturation.
Yeah.
So do you want me to comment on other things, or was just
there's so many people in the chat who are commenting. I think that's a great, I'll reinforce what you said. If you look at these vital signs, you're like, I already know there's going to be a fever. The patient has night sweats. And what's new is what you latched on to, is the low oxygen. And that, I think, reinforces what you said earlier, like cough, but now has low oxygen. That changes the calculus for us for sure. Hans mentioned something about smoking and COPD. Hans, do you mind elaborating on what you said in the chat about COPD and smoking? Oh, I think you're still muted, my friend. Take your time. It's okay.
Okay, I found it again. The button was on the left lower end. It's a bit unusual. She's only 61 years old. She's not smoking. So if she didn't have IBD, I would consider COPD rather unlikely in such a patient.
100%.
Unless there is a genetic connection, yes. But that would have shown earlier. So that's probably a strong indication of the connection between her Crohn's disease and the pulmonary system.
Oh, Hans, on point, 100%. I completely agree with you. I will leave it to the chat to try to guess what genetic disease you were alluding to, and we'll like to highlight that whoever jumps into that in a moment. But I completely agree with you. I think COPD is unlikely in somebody who's 61 who does not have a prominent smoking history. And there are two exceptions to how can you get COPD, true COPD, without smoking and without a genetic disease. And that is biofuel exposure. So in the in a lot of the world, yes, there we go. Mario said it. Biomass exposure. People cook indoors, and it is really that cooking. Which I'll ask, since Mario is picking up on the food theme today, I'll ask Mario to elaborate on that. But hey, Drew, tell us more about alpha-1 antitrypsin.
So alpha-1 antitrypsin deficiency. I think, if I remember correctly, I think Gabrielle had presented a case.
That's right.
Is like his first. Yeah. Okay. Good. So I was remembering it correctly.
Of course.
It's one of those interesting genetic conditions where you get very early COPD with minimal smoking exposure, but you also get liver manifestations as well. So cirrhosis being the most common one.
Superb. That's a great one-liner. I encourage you to keep your one-liners just like Drew did. It's short and sweet. You can't remember much more. So I code alpha-1 antitrypsin as a genetic disease with lung and liver manifestations, period. And then if I need to learn more about it, if I need to treat patients with it, I'll learn more about it. But I think that's as much as most brains can remember. That's a great job, Drew. Mario, you were making some connections between the food exposure and the clinical syndrome, and then we're teaching us a little bit about biomass. So please unmute yourself and elaborate on them, please.
Well, in Peru, especially in the north, it's a very typical association to eat raw crabs. I'm not sure if that's what I mentioned, seafood. I'm not sure if it's all seafood, but I'm pretty sure it's really associated with the life cycle of this. It's the lung fluke called Paragonimus, especially westermani, that causes like a pneumonic syndrome with eosinophilia.
Brilliant.
So that's something to mind.
Superb. Yes, Paragonimus westermani is prevalent in many parts of the world. And in the United States, if you're listening to this from the US, we do have Paragonimus in the United States, in the Midwest specifically, but it's a different kind of Paragonimus, but still on the DDX, even without travel outside the United States. Thank you so much. What about biomass exposure? What can you teach us about that, Mario?
Besides smoking, I think inhaling biofuel, especially in closed encounters, like it's very typical for in the highlands in Peru, where not only the highlands, but especially in the highlands where they cook in small houses, and these houses are typically enclosed, so to protect them from the cold weather. They get the same increased proteases in the lung, causing emphysema predominantly COPD.
Beautiful. Superb. Okay, you know what I'm going to try to do? I'm going to try to analyze this data, but I will ask a favor of Sandra to try to come up with a problem representation in English, and maybe in the chat you can come up with a problem representation in as many languages as we can, and we'll try to get them on the board. Okay, so Sandra, I'll give you some time to collect your thoughts and come up with a problem representation in English. In the meantime, I'll say that I am inclined to keep this very non-specific. We're getting a lot of signal we have inflammation and we have ulcerative colitis in the background. We also know that the ulcerative colitis has likely affected the lungs because the patient has bronchiectasis. So in the background, we have UC plus bronchiectasis, and in the foreground, we have inflammation that's subacute. We have a pulmonary fingerprint of this disease based on the hypoxemia and the crackles on lung auscultation. And we have a less robust evidence of disease in the abdomen by the patient's abdominal pain, diarrhea, and right upper quadrant tenderness. The disease process in the lung is confirmed by the hypoxemia. The disease process in the abdomen is questionable because the value of abdominal pain, diarrhea, and right upper quadrant tenderness is notable, but it's not perfect. Many patients with this symptom complex may have no readily available explanation. So I know there's something going on in the lungs, and I'm curious to see if there's something else going on in the abdomen. And we'll certainly rely on labs and maybe a CT scan of the abdomen and pelvis to help clarify what's going on there. And in the background, that's all I can say for sure. And then related to that is all this exposure history. What could hiking do? What could swimming in fresh water do? I won't begin to understand how that relates until we clarify what is the lung problem and what is the GI problem. If the lung problem is migratory infiltrates, I'll start to think about parasites. If the lung problem is a cavitary lesion, I'll start to think about environmental exposures from hiking. If the lung problem is diffuse alveolar hemorrhage, I'll start to think about leptospirosis. If the lung problem is a unilateral consolidation, I may be like, Kushal, I hate you so much for distracting me with all this travel history. This is just regular old community-acquired pneumonia. So we'll see. But for now, I think we really have to understand the problem better before we start to develop connections with what this very juicy Kushal-esque history is giving us. So Sandra, I'll give the mic to you for a problem representation, and we'll encourage the chat to try to get some more in other languages.
Okay, I was preparing it, but I'll try. I was checking the format, but that's okay. I can do it right now.
Yes, you can.
So I could say like a female patient, 61 years old with a history of ulcerative colitis. I'm sorry.
Yes, that's okay.
That presents with a history of cough, dyspnea, and weight loss with a 4 months period of evolution. Associated with the symptoms, also it's weight loss of 24 pounds. So, yes, I'm sorry. I think.
No, that's wonderful. That's perfect. I'm not sure. Okay. I think that's perfect. You got the key background data. You got the age, you got the gender, you got the key background data, and then you describe the syndrome: cough, dyspnea, weight loss. And then the question is, do we include the abdomen or not? And I think you probably would include the abdominal pain because we don't know if that's part of the signal or not. Tiago just messaged me that Rafa lost his connection, so I think Tiago has the case. So Tiago, do you mind just giving us the next, well, thank you for jumping in, number one. And do you mind giving us the next set of data?
Thanks.
Oh yeah, so Rafael just sent me the case a few minutes ago. Probably he will be back, but I can continue. So the white blood count was 2.1, hemoglobin 10.2, platelets 91,000, AST 103, ALT 105, alk phos 213, gamma was 191, bilirubin was normal, albumin 2.7, total protein 8.9, BMP normal, HIV negative, hepatitis panel negative, CMV PCR negative, stool, ova, and parasites negative, strongyloids serology negative, cryptosporidium antigen negative, urine histoplasma negative, blood cultures 2 pairs showed no growth. CT chest, multifocal bronchiectasis, numerous randomly distributed nodules, mediastinal lymphadenopathy. And MRCP was done due to the history of ulcerative colitis, and it didn't show changes suggestive of primary sclerosing cholangitis. And I'll stop there, and the next aliquot there is the diagnosis.
Okay, all right. Sandra, what do you think about the CT?
Everything low, so that's shouting there. Yeah. Every time that I see either all the results like high pancytopenia or pancytosis. In this case, pancytopenia. It makes me think that it's something that's affecting it could be something affecting the bone marrow, or something immune that's more general, and it spreads through the body. So that's are my initial thoughts, but related to and we know that the ulcerative colitis, it's already an immune disease, so that can predispose to other immune diseases. And looking to the other exams, so we were concerning about like having any infection on everything it's negative, so I would stick with an immunologic manifestation that could be related to her ulcerative colitis. And also she has COPD, and you said she didn't smoke. We're not sure if she's been exposed to biomass or other toxics. And if she was happen to have a alpha-1 antitrypsin deficiency, we would expect most likely to have problems in the liver as well. And also the age of onset usually is 40 years old. So I'm still not sure about the diagnosis, but I would think that I would think something that's more on the immunologic system.
I agree with you. I mean, I think at the end of the day, we cannot know what the final diagnosis is, but let's try to make some progress. Pancytopenia usually means that there's a problem in the bone marrow, but there are 3 causes of peripheral destruction of all 3 cells at the same time. Actually 4. You can have splenomegaly destroy all cells, but that's not present here because we don't see it on the imaging.
Yeah.
What other process can destroy the cells outside the bone marrow? Lupus? No evidence here. Tick-borne illness? Possible. Could she have a tick-borne disease process? She's been have a lot of outdoor exposure and is here with fevers, liver enzyme elevations, and pancytopenia. What makes that much less likely? There's only one tick-borne disease that tends to affect the lungs, and that's tularemia. Think about Lyme disease, ehrlichiosis, anaplasmosis, rickettsial diseases. Very rarely affects the lungs. The overlap between tick-borne disease and POEM is very low. And the pulmonary disease process, I think, is the clue here. What we see in the lungs is we see randomly distributed nodules. What this means is this is essentially metastatic disease to the lung. What does that align with? It aligns with a disseminated granulomatous infection or a disseminated hematological malignancy. Now here's the problem. You cannot know for sure, but hematological malignancies also are less likely to go to the lung. The overlap between lymphoma/leukemia and lung is small, very small. And in a patient who is on infliximab, you really have to prioritize an infection before you you exclude anything else. Okay, so we have pancytopenia, a peripheral destruction from lupus, tick-borne disease, and CLL is unlikely. So we know something is going to the bone marrow. Now, what could go to the bone marrow? Granulomatous infection, which is compatible with what we see in the lungs. Lymphoma, which is less compatible with what we see in the lungs. And then autoimmune diseases. What autoimmune disease can affect the lung in this way and go to the bone marrow? Sarcoidosis. Okay, so lymphoma possible, but less likely because lymphoma very rarely, but involves the lungs. Granulomatous infection, very possible. What granulomatous infection could this be? Tuberculosis, for sure, but the residence in the United States and a lack of a prominent, extensive travel history makes that less likely, but very important to rule out. Nocardia, possible, but doesn't go to the bone marrow as often as it goes to the skin. Endemic mycoses, possible. Histo, urine antigen is not perfect, but is pretty good for disseminated disease. Paracocci not at play here because of the epidemiology. Coccidioides antibodies Cushon mentioned in the chat was negative. Disseminated non-tuberculous mycobacteria is important to consider because of the bronchiectasis, but that's a little bit less likely. So where are we? We know that this is very likely a granulomatous disease process because the overlap of pancytopenia and lung manifestations really is a signature of those disease processes. What granulomatous infection should we entertain? Mycobacterium tuberculosis, less likely based on epidemiology. NTM because of bronchiectasis. Nocardia, probably not. Salmonella typhi, probably not. Bartonella Hensley, probably not. No exposure. Brucella, no clear exposure history based on what she's eating. Endemic mycoses, we might land on one rare but important possibility induced sarcoidosis. So I'll go back to the first schema we shared. Remember this? Right here. So the key question is, are we going to find an infection? And if we don't find an infection, is this drug-induced pulmonary and bone marrow sarcoid? And at the end of the day, this could be the rare possibility of TNF alpha induced lymphoma with the rare presentation in the lung. I'm going to look at the chat now because I minimized it to try to collect my process and see, I just to address some comments. Nalayan, one fascinating thing about leishmaniasis is the relative sparing of the lungs. It really is very, very curious why it causes such profound granulomatous disease, but tends to spare the lungs. Gabrielle, brucella for sure is an important consideration. And I'm scrolling real quick, and I think that everything else we reflected on. Yep. All right, cool. If you have anything else to add, please put it in the chat now, and I'll try to highlight it in a moment. But in the meantime, we'll give Tiago the mic to summarize where the case ends.
Okay, so the final diagnosis came from an induced sputum culture. So the Mycobacterium tuberculosis was negative, and they performed an AAT and it was negative. But 2 of 3 samples grew Mycobacterium avium. So the final diagnosis is Mycobacterium avium.
Kushal, if you're here, please unmute yourself and teach us what you learned from this case. If you're not here, I'll be so sad, but that's okay. Is he here?
Yeah, you guys were on the right track. You guys were on the right track. I was trying to distract with the social history, but infliximab would predispose patient for mycobacterial infection. And as you said, patient didn't have any travel history, so NTM was much more likely than MTB. And the other thing you mentioned already, that patient would have disseminated NTM signs and symptoms, like she has pancytopenia, she had alk-phos and GGT elevation, and she had miliary pattern in the CT scan. So those are all pointing towards it.
Amazing. Can you tell us how the patient did?
She did great. Covered it really great.
Amazing. And maybe you can give us 1 or 2 minutes on how what you know about treatment of NTM. I think it's a good overview for us to learn if you have that knowledge handy.
Let me pull it up. I think it's clarithromycin, rifampin, and ethambutol.
And one thing I'll add to that as you pull it up is just the duration of therapy is very, very long. So you really have to, it's a very toxic therapy and is very, very long standing. Sandra, while Coach Hao pulls that up, what thoughts, reflections do you have before we conclude today's case?
Yes, that was really interesting. So regarding the pancytopenia, I always think about bone marrow, but it was a teaching point for me is always remember the other causes, and I was ruling out infections, but it's really it was a really important history to know that, to pay attention that she was taking the infliximab, and that was a really important thing to pay attention to. And also with all you described, there will be less likely to have a TB by Mycobacterium tuberculosis. But it was still open to other infections that could have granulomatosis disease or could affect all the cells. So that's all. Thank you so much.
I think that's the core teaching in this case. Thank you for highlighting it. All right, Zakrini, please take us home.
Thank you, everyone. So today, to summarize this case, we can maybe think of this as one giant problem representation because we have so many up today. So the problem representation consists of 3 main things, which is the clinical syndrome, the time course, and who the patient is. So if we break down the clinical syndrome, we're essentially investigating 3 main symptoms: the dyspnea, the cough, and the weight loss and night sweats. And like Dhruv and Ravi did today was essentially to boil these big symptoms into a word or a sentence that we can remember more easily later on. So so how do we think of this dyspnea? Think of the dyspnea pyramid and the base rate. So we prioritize a cardiopulmonary disease over something that's metabolic, psychiatric, or neurological. The weight loss we equated to inflammation, and then thinking about the IMAID mnemonic, infection, malignancy, autoimmune drugs, and endocrine. The cough, as Thiago told us today, was essentially localized just to the respiratory system. But as Ravi said, with the caveat that it localizes only the pathological process, not the disease to the lung. So think about whether the disease could be in the lung or the heart, the kidney, or the neurological system. And something very interesting we learned today was how the productive value of the color of the cough is very poor, except in 2 situations. The first, the presence of change of color in COPD patients, and the second, if there's accompanying hemoptysis. The second part of our problem representation essentially revolves around who the patient is. And here he had a background of ulcerative colitis and COPD. There was also a lot of social history, but I think our big key discussions revolved around these two diseases. So how do we think about ulcerative colitis with pulmonary symptoms? We think about what this patient is being treated with and his immune status, as well as what are the disease associations. If we were to break down these disease associations further, as Rabi taught us, you think about 2 things: the tubes of the lung and the vessels. So thinking about the tubes from top to bottom, you think of subglottic stenosis, necrotizing tracheobronchitis, bronchiectasis, and then bronchiolitis. Bronchiectasis being the most common manifestation. And then think about the vessels, like something like Takayasu's or a hypercoagulable state. The second part of who this patient is was that this patient had COPD at a relatively young age. What are the 3 risk factors that you think of? Smoking, genetic, and biomass exposure. As Dhruv taught us today, alpha-1 antitrypsin deficiency is essentially a pathology that affects both the liver and the lung. And then finally, we could boil down this problem representation into 2 things, the pancytopenia and the lung involvement. And then we discussed a framework of how we think about this as being either a bone marrow problem or a problem outside of it, but prioritizing the bone marrow. So within the bone marrow, think of 3 things: granulomatous infections, lymphoma, and autoimmune diseases. Outside of the lung, we can think about splenomegaly, lupus, tick-borne illness, and CLL. And another interesting part is that tularemia is the only tick-borne illness that affects the lung. I hope you all had a great time.
Absolutely brilliant stuff, Sukriti. See you all next Saturday, I hope. Take care.